Up to this day, we treat depression according to monoamine theory. We believe that depression is caused by deficiency of neurotransmission, which can be caused by low levels of serotonin and norepinephrine and to a lesser extent dopamine in the synapse. So we believe that depression is caused by decreasing amount of serotonin and norepinephrine in the synapse. So how to treat depression? The most obvious approach is to increase the amount of serotonin and norepinephrine in the synapse. And drugs that cause increase in serotonin or norepinephrine in the synapse we call antidepressants. To tricyclic antidepressants belong amitriptyline, nortriptyline, imipramine, desipramine, clomipramine, doxepin, and amoxapine. Tricyclic antidepressants have two mechanisms of action. First of all, they inhibit norepinephrine transporter. And to explain this, we have to know how adrenergic neurons work. So we have presynaptic neuron, synapse, and postsynaptic neuron. Adrenergic neurons uptake tyrosine. Once tyrosine appears inside the neuron, tyrosine undergoes hydroxylation by rate-limiting enzyme tyrosine hydroxylase with formation of L-DOPA. Then L-DOPA by DOPA decarboxylase is converted to dopamine. Once dopamine is formed, vesicular monoamine transporter puts dopamine inside the vesicles. In the vesicles, dopamine molecules undergo conversion to norepinephrine. And in this form, norepinephrine is stored inside the neuron. But once depolarization occurs, neuron pushes vesicle into the synapse. We call this process exocytosis. As a result, vesicle becomes destroyed and norepinephrine molecules income to the synapse. On postsynaptic neuron, we have numerous adrenergic receptors. It's alpha-1 receptor, beta-1 receptor, and beta-2 receptor. Once norepinephrine molecules appear in the synapse, most of them immediately bind to adrenergic receptors. With binding, they activate adrenergic receptors, and activation of adrenergic receptors improve mood and increase energy. Some of the norepinephrine molecules bind to alpha-2 receptor on presynaptic neuron, which is autoreceptor. With activation, this receptor inhibits the exocytosis of norepinephrine vesicles into the synapse. So this receptor provides reciprocal regulation. But what happens to norepinephrine molecules that simply did not have time to bind to any receptor? On presynaptic neuron, we have norepinephrine transporter called NET. This transporter uptakes free norepinephrine molecules and delivers them back to the presynaptic neuron, where the big bad boy monoamine oxidase B waiting for them. Most of the delivered norepinephrine molecules have a tragic fate. Monoamine oxidase uptake and destroy them. But some norepinephrine molecules are able to slip away from monoamine oxidase, and such molecules income to norepinephrine molecules inside the vesicles, thereby replenishing norepinephrine pool. Tricyclic antidepressants inhibit the function of NET transporter. With inhibition of NET, the reuptake of norepinephrine into the presynaptic neuron decreases. So more norepinephrine molecules will remain in the synapse, where now these free norepinephrine molecules begin to bind to adrenergic receptors, thereby additionally stimulating them. With time, because norepinephrine transporter is now blocked, in the same fashion, even more norepinephrine molecules accumulate in the synapse. The higher the amount of norepinephrine molecules in the synapse, the higher the stimulation of adrenergic receptors, and thereby, potentially, the better becomes the mood, and also the more energy increase. So, tricyclic antidepressants inhibit the function of norepinephrine transporter. This causes decrease in reuptake of norepinephrine from the synapse, thereby the amount of norepinephrine molecules in the synapse increase. And the higher the amount of norepinephrine molecules in the synapse, the higher the adrenergic effect, and thereby the better becomes the mood and the more energy increase. But also, tricyclic antidepressants inhibit serotonin transporter. And to explain this, we have to know how serotonin neurons work. So we have presynaptic neuron, synapse, and postsynaptic neuron. Serotonin neurons uptake tryptophan. Once tryptophan appears inside the neuron, tryptophan undergo hydroxylation by rate-limiting enzyme tryptophan hydroxylase, with formation of serotonin. Once serotonin is formed, vesicular monoamine transporter puts serotonin inside the vesicles, and in this form serotonin is stored inside the neuron. But once depolarization occurs, neuron pushes vesicle into the synapse. We call this process exocytosis. As a result, vesicle becomes destroyed, and serotonin molecules income to the synapse. On postsynaptic neuron, we have numerous serotonin receptors, and once serotonin appears in the synapse, most of them immediately bind to serotonin receptors. With binding, they activate serotonin receptors, and activation of serotonin receptors improve mood and increase energy. Some of the serotonin molecules bind to serotonin 1-beta receptor on presynaptic neuron, which is autoreceptor. With activation, this receptor inhibits the exocytosis of serotonin vesicles into the synapse. So this receptor provides reciprocal regulation. But what happens to serotonin molecules that simply did not have time to bind to any receptor? On presynaptic neuron, we have a serotonin transporter called SERT. This transporter uptakes free serotonin molecules and delivers them back to the presynaptic neuron, where the big bad boy monoamine oxidase A waiting for them. Most of the delivered serotonin molecules have a tragic fate. Monoamine oxidase uptake and destroy them. But some serotonin molecules are able to slip away from monoamine oxidase, and such molecules income to the newly formed serotonin molecules, thereby replenishing serotonin pool. Tricyclic antidepressants inhibit the function of serotonin transporter. With inhibition of SERT, the reuptake of serotonin into the presynaptic neuron decreases. So more serotonin molecules will remain in the synapse, where now these free serotonin molecules will bind to serotonin receptors, thereby additionally stimulating them. With time, because serotonin transporter is now blocked, in the same fashion, even more serotonin molecules accumulate in the synapse. The higher the amount of serotonin molecules in the synapse, the higher the stimulation of serotonin receptors, and thereby, potentially, the better becomes the mood and the more energy increase. So, tricyclic antidepressants inhibit the function of SERT transporter. This causes decrease in reuptake of serotonin from the synapse, thereby the amount of serotonin molecules in the synapse increase, and the higher the amount of serotonin molecules in the synapse, the higher the serotonin effect, and thereby the better becomes the mood and the more energy increase. The major problem with tricyclic antidepressants is a huge amount of side effects. First of all, tricyclic antidepressants block alpha-1 receptor not only in the CNS, but also in the blood vessels. Once alpha-1 receptor is blocked, vessels dilate. With the vasodilation, resistance of the blood vessels decrease. Recall that blood pressure is equal to cardiac output on systemic vascular resistance, and cardiac output is a stroke volume on heart rate. As we see, with vasodilation, resistance decrease, thereby blood pressure decrease. so hypotension develops. And in response to hypotension as a compensatory mechanism, heart rate increase, so tachycardia develops. We call this reflex tachycardia because we increase heart rate to keep blood pressure steady. Because tricyclic antidepressants block alpha-1 receptor, vessels dilate, blood pressure decrease, so there is increased risk of orthostatic hypotension, and in response to this, reflex tachycardia develops. But also, we have two other receptors. It's muscarinic receptor and histamine type 1 receptor. And in addition to this, we have sodium channels. And guess what? Tricyclic antidepressants block them too. With blockage of muscarinic receptor, atropine-like effects develop. It's decrease in urination, increase in heart rate, and dry mouth. Blockage of H1 receptors cause sedation, and also it causes increase in appetite. And with blockage of sodium channels, the rate of heart conduction decrease. So in addition to alpha-1 receptor, tricyclic antidepressants block muscarinic receptor. Thereby, they can cause increase in heart rate, urinary retention, dry mouth, confusion, or hallucinations. Also, they block H1 receptors. This can cause sedation, increased appetite, and thereby weight gain. And in addition to this, they block sodium channels, and this can cause quinidine-like effects, which are decrease in heart conduction that can manifest as IV block, and also they prolong QT interval, which is very dangerous side effect because it can cause life-threatening arrhythmia, torsates the pointers. And to prevent arrhythmia, we use sodium bicarbonate. Because of a huge amount of side effects, nowadays tricyclic antidepressants are usually never used as a first-line drugs. Typically, they are second-line drugs. We use them in major depressive disorder as a second-line option because we have selective serotonin reuptake inhibitors as a drug of choice. Also, we use them for peripheral neuropathy, for chronic neuropathic pain. In fibromyalgia, we use amitriptyline. For migraine prophylaxis, we use doxepin or amitriptyline. As we see so far, tricyclic antidepressants are really good in management of pain, primarily neuropathic pain. Also, for obsessive-compulsive disorder, we can use clomipramine. And tricyclic antidepressants can help in enuresis, and the reason is that they block muscarinic receptors, and thereby they decrease urination. For enuresis, we use imipramine as a second-line drug, because the drug of choice for enuresis treatment is desmopressin.